All right, so let's talk about why we're here, first of all. So we're here talking about health and particularly weight management, right? Whether that means weight loss, or some people might mean weight gain, you know, what's a healthy weight? And this came out of having a lot of discussions with patients that we've seen here, some of our loved ones, talking to them about high blood pressure and diabetes and cholesterol, or just overall wellness, and just some of the questions that we've gotten, you know, what is healthy weight? What does it mean? How do you know when you get to that point? And just, you know, talking to them about the impact that weight has on your overall health. And so that was why we wanted this to be one of our first events. And so one other thing too, do we have the note cards as well? Or are they back here? So after, you know, I'm going to introduce our panelists for tonight, but like I said, we're going to open up for questions later. If you're shy and you don't want to necessarily ask your question out loud, we're going to pass around note cards. If you want to just write your question down on a note card and pass it over, then we can answer those as well. And we have some extra pens around if you need them. All right, so without further ado, all right, and you guys are sitting in the order. Oh, wow. Awesome. All right, so first I have Dr. Michael G. Knight. He is a board-certified internal medicine physician, so adult medicine, as well as obesity medicine. He practices at the George Washington Weight Management Clinic and general internal medicine practice in DC. So he came up just for this to talk to you guys tonight. And his clinical interests include chronic disease management, so that's things like high blood pressure, diabetes, other more complicated things, minority health, sexual health, and obesity. Dr. Knight has received numerous awards for his professional and clinical practice, including the Top 40 Under 40 Leaders in Health Award by the National Minority Quality Forum and the Top Healthcare Professionals Under 40 Award by the National Medical Association. Now, Dr. Fatima Cody Stanford also traveled. She flew from Boston. She is a fellowship-trained obesity medicine physician at Massachusetts General Hospital, Harvard Medical School. She completed her obesity medicine and nutrition fellowship at MGH after completing her internal medicine and pediatrics residency at the University of South Carolina. So she's adults, kids, and obesity. Upon completion of her MPH, she received the Gold Congressional Award, which is the highest honor that Congress bestows among America's youth. And in 2019, so this year, she was selected as the Suffolk District Community Clinician of the Year and for the Reducing Health Disparities Award for MMS. That's Fatima. And last but not least, we joke, his name is Dr. Tyree MS Winters. He's another Ty, so I refer to him as the other Ty, but he refers to me as the other Ty. So we'll see how long this debate keeps going on. But I have the mic first. So he is a board-certified pediatrician, and he's local. He has extensive clinical experience in adolescent medicine as well. He is actually the Associate Program Director of the Pediatric Residency Program at, is it Goriab? Goriab Children's Hospital, which is at Morristown Hospital, and Medical Director of the Health Start Clinic. He's originally from Detroit, which he usually tells everybody that meets him. He got his Bachelor of Arts in Psychology from the University of Michigan, and he completed his osteopathic medical education at Ohio University Heritage College of Osteopathic Medicine. And he completed his pediatric residency at Nationwide Children's Hospital and is a fellow of the American College of Osteopathic Pediatricians. Sorry. So like I said, I'll start us off with some of the burning questions that have been coming up. If at some point, though, a topic comes up and you want to follow up right then, feel free to raise your hand and we can interject. You don't have to feel like this is a formal talk. They're here for you. They're here to answer your questions. I just tried to kind of collate some of the ones that I hear more often, but if you have other ones, like I said, feel free to interject, or when we're done, you know, you can get up and ask your questions as well. Sound good? Yes. Okay. All right, so we'll start off with easy ones. So we all know that folks can focus a lot on their weight and their size when it comes to like vanity, right? They'll say, oh, I want to get my summer bod, right? And they want to be able to wear a bikini. But can you guys talk to us about what impact does weight actually have on your health? And in particular, someone who may say, well, I'm otherwise healthy. Like, who cares if I have some extra pounds here or there? Do they need to care?
think it's important for us to recognize that when we think about obesity, it's actually a disease process. It's not just a size, there's actual pathophysiology. And by that I mean that I could actually draw diagrams to explain how your brain regulates weight, okay? So when we think about it, yes, when we look at obesity, I can look at someone and say they may have the disease of obesity, but it's important for me to recognize that there is pathology behind it, okay? So when someone comes into me and they're like, oh, well, you know, I have no problems, but if you have obesity, that is indeed a problem. And it leads to downstream impacts of many other disease processes. It leads to heart disease. It leads to things like obstructive sleep apnea. It leads to different cancers. We know of about 100 different diseases that are associated with obesity. And I personally think that one of the major issues that we have here in the US, and especially within our community, is that we go and we address all of the other issues instead of addressing the primary issue, which is that obesity. So if I'm working with a patient that has obesity and we actually address the obesity and we corner that, what I find is that I'm able to remove medications for a myriad of other issues. So maybe I'm taking away several of their high blood pressure medicines. Maybe they no longer need their CPAP machine. Maybe they go off of some of their asthma medications. And so that's, what other disease can we really say that about? If I treat one of those things, I now still have to deal with everything else. And so I think that's really kind of how I think about obesity as a disease, both in the pediatric and adult population. And I really am keen on making sure that we really address the disease so that we can tackle the downstream effects. So that's my thought.
I think one of the things, just to add to that, having excess weight is so complex. I think a lot of times we see, if I have excess weight, all I need to do is eat less, exercise more, right? Anyone heard that before? And so as an internal medicine physician, so when you go and get your physical or your checkup, I'm the kind of doctor that you would see. And many times it's easy for me to say, okay, blood pressure's up, let me give you this pill, right? Your sugar level's too high, we're gonna put you on this pill, but the weight's too high, what do I tell you? So the physician will say, well, we want you to exercise a little bit more, let's cut back on the sodas, and that's probably as much as you get, right, in your 15 to 20 minute visit. But what we know is that it's so much more complex than that. And so in my medical weight management practice, when we have our visits, we're strictly focusing on weight, and it takes many, many sessions to understand what every individual is going through and their journey with weight. Everyone is different. I have patients who gained weight in the past year. Some people have been living with excess weight since childhood, and their experience and how it impacts their health is going to be different. And so one of the things we want to bring out on the panel tonight is that understanding it's a complex process. It affects everyone differently. There are many people who have many excess pounds, and it seems like they're extremely healthy. And someone who just has a little, they're having all these medical conditions that we don't understand why. So hopefully, after we discuss tonight, we'll learn a little bit more about the complexities behind it, but also how you can effectively address a healthy weight for you.
I just want to say, in addition to what Dr. Gaines had just recently said about me, I also was the director for pediatric weight management at Newark Beth Israel Hospital. One of the things that I saw, I'm happy that you brought up the comment about in terms of vanity. So when I see a lot of my patients that come in, and I see a lot of adolescent patients that come in with concerns about weight, one of the things I usually bring up to them is, even though it may seem as vanity is kind of a negative way of looking at it in terms of weight loss, I always say one of the things is, whatever your inspiration is, that's valid. I cannot invalidate or invalidate your concerns about, I want to join the dance team, or I want to join the wrestling team. And so using that as a way of motivation to be able to say, like, you know what, let's start to have these conversations about weight, I find it is very helpful. And one of the things I also find is that you will get a better participation and outcome with these kids and with adults, I'm assuming, if you go by what is their valid reasons.
Thank you.
Thank you. It's true. I actually I've been traveling a lot, and so I've been working out with these videos. One of the companies called HasFit, and somewhere halfway through the video, when you're ready to give up, he goes, "Remember why you're doing this." I'm like, can he see me? But it's true. Like you have to remind yourself whatever the motivation is, big or small. Awesome. So speaking of children, since you brought that up, we'll go to my next question, which is, what impact does being overweight as a child have on adulthood obesity? Because sometimes you hear parents will say, oh yeah, you know, we'll just let them have some exercise. They'll grow out of it when they get older. Or, yeah, I was a little chubby when I was little, but then look, I'm fine now. What are your thoughts around children, and should they be dieting? What should they be doing as far as that?
I'm going to start on this.
Okay.
This is going to be a common theme this evening. So I love you guys. As someone that takes care of both children and adults, I think it's important for us to recognize, and I think I'm losing my.
Oh, there you go.
It's important for us to recognize that childhood obesity leads to poor health outcomes once that person becomes an adult. So much so that if patients have severe obesity and require something like weight loss surgery, we will operate as early as 13 at Mass General Hospital. And what we have just done is we just submitted a study where we're comparing the outcomes of adults that go to surgery.
Just the way you're, yeah.
Oh, something like this.
Yes.
Oh, this is delightful. Adults who go to weight loss surgery versus pediatric patients, both will do well. But what we find about our pediatric patients is that actually by the time we send them to surgery, their weight is significantly higher than our adults. So if we look at what you guys may have heard of, it's called body mass index, okay? So a body mass index that is greater than or equal to 30 is a definition in adults of having obesity. Now we have mild, moderate, and severe obesity. So mild would be a BMI of 30 to 34.9, and a BMI of 35 to 39.9 would be moderate obesity, and anyone that has a BMI of greater than or equal to 40 has severe obesity. Now, when we look at this and we look at the BMIs, or the body mass index of our kids that we send to surgery, their average BMI when we send them to surgery is 54. The average BMI for our adult patients we send to surgery is 44. So you can say that 54 is higher than 44. I mean, we don't need rocket science to figure that out. But what we find is that despite them having a much higher body mass index, when we send them to surgery and we look at how they do 5 years later, on average, they do significantly better. And let me tell you why I think that is. The reason why is because they have had not a long exposure to, let's say, having type 2 diabetes. If they've had it for 1 year versus the 65-year-old woman that I send to surgery who's had type 2 diabetes for the last 40 years, then that is a difference in terms of how the body will respond and how it will resolve that metabolic disease. So no, this idea of like, you know, outgrowing it, not an issue, you know, that's not something that we want to promote. And it's also important for us to not promote in either population, both in children and or adults, this idea or concept of dieting. Die is in the word diet, right? So this is not something sustainable. I want something that you can do and sustain for the rest of your life. So let's not jump on the next fad, because you guys know that the next fad is out right now. Well, we have keto, we have this, that, and the other. It's just Atkins reinvented from the late 90s, if you guys really think about it. And we see how that turned out, and we also know that Dr. Atkins isn't living. He had a ski accident. But the whole point is that we have to think about things that are long-term and sustainable for both our peds and for our adult patients to lead to better health outcomes. I'm going to have you weigh in now.
So let me tell you about the system. Every time we get together, it's just the same way. We start having conversations, and I'm like, okay, I'm gonna let her start. I'm gonna wrap it up. So let's get real. So one of the things, especially for me, so kind of similar with the training that both of my colleagues have had with obesity training I had at Nationwide Children's. Now, if you're unfamiliar with Nationwide Children's, it's one of the top 10 children's hospitals in the country, and we do quite a bit of pediatric weight management. And in that case, I was more of a boots on the ground type of guy, where I worked with children day in and day out, always in the inner city. So when I worked with these children, one of the things that you would always get, and I always told even my trainees when they come after me, is doing obesity medicine and pediatrics, you might as well just cut an onion open and start peeling it layer by layer, because that's how every visit is going to go. Every visit is going to go where when we pull another layer, everybody in that room going to start crying, everybody going to start remembering how it is, and that's a lot of transference, especially from the parent to the child and back. And the reason why is because when you start to have a conversation with the parent about a child, with the elevated BMI, the first thing that typically happens is the transference on a parent. Whether you are saying that this parent is not parenting correctly, or whether you're saying, well, if you're saying that my child has a weight problem, then you're saying I have a weight problem. So it's this feeling of judgment that goes on, and it turns into a very sticky situation. And what you have to remember is, this is the time now where you're not trying to place blame on someone, you're not trying to have a conversation about what was right, what was wrong. Just a personal story, I've always battled with my weight. That was one of the reasons why I wanted to go into obesity medicine, is because this was me. I was that child in the room with my pediatrician, who was a phenomenal black woman from Howard University, back in graduated 1957. And she would always talk to my mom about it. And the thing is that my mom was a college educated woman, but she grew up with the same type of Mississippi Creole mama that I had, which said, you know, you finish your plate. When I made this food, we don't go to McDonald's. I ain't never gone to McDonald's hardly. McDonald's to me is a treat still to this day. Because McDonald's was at home. But what she would do is, when we made food at home, my mom would make us larger portions. Because she wanted to make sure that we was full, because we were bigger people. You see, I'm 6'6". We're bigger people, so it's like, oh, you gotta get full. And the thing is that was the biggest mistake that my mom was making, that my doctor had told her about. And by the time that we started having this conversation and we were talking about it, my mom was receptive, but I also know it hurt my mom's feelings as well, right? And that's what we have a big issue with when we're thinking about the pediatric world. Just tying it back into going to the adult world, which is now you have parents that are having concern because we don't want our child to feel some kind of way because we're feeling some kind of way, may or may not, and then it leads on into adolescence. By the time we get to adolescence, we're going into adulthood, and it's just a vicious cycle that keeps repeating itself over and over again. So I'll let you go.
Well, that kind of segues into, have a couple questions off of that, but I'll start with the one. So in particular, for those that aren't familiar as much with Jersey City, we're one of the most diverse cities literally in the country, right? So another thing that we find as we talk to patients is that race, ethnicity, culture, and what all of that means around food and weight plays a big role, right? So sometimes I hear things that are like, well, if I stop eating that, what am I gonna do when I go home for Christmas? Or, you know, if I get too thin, then folks will say something about that. You know, there's some cultures where to be thinner is a bad thing, right? Especially some other countries. In my travels, I've seen billboards that basically showed the, it's like the opposite of the US to some degree. They showed the very thin woman as the sad poor woman, and the thicker woman was the richer woman because she could afford the good food, right? She didn't have to ration. So, you know, when you're dealing with a population of people from different places, they're not necessarily coming either with the concept of being thinner is better. And not to say that that is the case from a medical standpoint, but you're not just trying to convince them to take seriously, you're also trying to combat whatever cultural things they're bringing to the table as well, whether parent to child or just the adult themselves. So what do you guys, like, how do you guys navigate around that, or do you have any personal stories about that?
This is such an important point. I think one of the challenges for folks, and this is not just with weight, this is what all of our health issues, you know, choosing your provider who you see, making sure it's someone that understands you culturally, understands you from where you're from, the community is so important. So if a patient comes to me with high blood pressure or diabetes or excess weight, I can easily tell them, okay, I don't want you to eat any of this food. I want you to have kale chips. I want you to have a little raw carrots, and that's all you're gonna eat, right? And then they're never gonna come back to see me.
Right.
So it's about being realistic. I spend time and go through, what are you eating for breakfast? What are you eating for lunch? What are you eating for dinner? And then we're gonna go individually through those items and understand how each of them are affecting their health issues. So I'm not giving you a paper and says, I want you to throw everything out in the pantry, everything, all your cookbooks out, and I only want you to eat what's on this sheet. That's not realistic for many people. And so the first thing is understanding culturally what's important to you. What kind of foods do you like? What kind of foods did you grow up with? And how can we transition there? One of the things that a lot of us have come up with thinking, and one of the myths that we're going to debunk tonight, is that all calories are equal. Right? And so in the 90s, everything low fat, low calories. You have 100 calorie packs, and I can have as many 100 calorie packs of these cookies because it's only 100 calories, right? No, wrong. So it's understanding that the way that we process different foods has a lot more to do with the type of foods. And so that brings in the concept of like macronutrients, right? So what does that mean? So when we're thinking about foods are going to be made up of mainly three things. So your carbohydrates, your fats, and your proteins, right? And the way that each of us processes that is very different. And so 100 calories of carbohydrates or highly processed carbohydrates is completely different than 100 calories of proteins or even fats. And so a lot of that low-fat trend, low this is really, we're understanding so much more. And so when we think about ethnically and culturally, it's understanding the foods that you eat, what is involved in them, what are the composition as far as protein, carbohydrates, how processed they are, and then really having an intelligent conversation about what can I have some of, what can I not have some of. Just when we think about even holidays, a lot of my patients, one time I was on in DC this year, they invited us to come to NBC and do this interview about, how do you eat healthy for the holidays? And on average, most people are going to put 5 to 10 pounds on during the winter holidays, period. And many times you'll lose it, but if you are really dealing with excess weight, a lot of times that gets you off track and you just continue to build from there. And so how do you do it? So we talked about having like 3 free tickets, right? And you go, you see the whole spread, and you choose 3 of your most favorite items. You have small portions, but you can still enjoy it. Now, it doesn't mean you could take the take-home plate, because that's what gets you, right? It's not Thanksgiving, it's a take-home container. So you go to Thanksgiving dinner, you can have the food there, but then it's Thanksgiving night, and then the next morning, or the next lunch, or the next dinner, the whole weekend, Monday, Thanksgiving dinner, right?
What are we going to eat for the weekend?
So that's the point. Sometimes people get so discouraged when they say, you can never have that cake again. You can never do this again, right? You think about birthdays, you think about all these other experiences. So it's not I'm trying to take things away. It's about how can we moderate what you're eating. Some things are a treat. Some things is only one time, not every night. But when you think about culturally, when we talk and tell people that this food that you've always eaten, you've grown up on, you love, you can never have it again, that really discourages people. So it's understanding how the food will interact with you and then how much of it may or may not be healthy for you.
So I'm from Atlanta, Georgia. That did not come out. So that's very important for you to understand who I am. And one of the programs that I helped design back in the early 2000s was a program called Healthy Body, Healthy Spirit. And in this particular program, we specifically went out to African American church communities, and we had Marla Gibbs as our spokesperson. Everybody loves Marla Gibbs, right? This was during the 227 era, if you guys are old enough to remember that. And so she would go through and she talked, we had her talk about some of the nutrients that were very important. We had a Healthy Body, Healthy Spirit cookbook where we were using foods that were more traditionally popular within the African American community, because we can go in and I can bring what we were doing at Emory University into that community, but if it doesn't resonate with that community, they're not going to do it. And the reason why that program was successful when we had the funding to fund it was because we were going into church communities. We know a lot of what we do, if you guys go to church, it happens around food, right? We have different, we have baby showers, we have weddings, we have this, that, and the other. We just have sometimes just a reception after church just to have one. And let me tell you, the cake after church is great. Let me tell you.
It's the fried chicken and spaghetti together.
It's important to us to recognize that we can do these things. And I think what Michael said was really, really important. It's not an all or none. Yes, we want to have things. So when I think about talking to my patients, I talk about lean protein, whole grains, fruits and vegetables being predominant in one's diet. It's not saying that you can never have that piece of red velvet cake or can never have that peach cobbler, but why don't we do that like twice a year? Let's say, I don't know, once a quarter. Michael gave you guys more. But so the thing is that it's not that you can never have it. It's not like saying on my birthday I can't have a slice of birthday cake. It's just recognizing that that can't be every single night. So the thing is, if you buy a sheet cake, that's gonna still be left, and you're like, oh, let me just put that in the freezer. No, let's just get a slice and then get rid of the rest. And that's a challenging concept because it's not how we've seen ourselves in terms of rewarding ourselves surrounding food. So that's my thoughts.
Okay. I was like,
But you bring up a good point too, because I think that a lot of times what we also don't talk about are people's narratives around food, right? There's some people that say, when I get stressed, I eat. When I'm happy, I eat. When it's celebratory. So is there a role for therapy sometimes? Or do you guys play a role of a therapist as you're doing your obesity or weight management consultations?
I know, so I can get anything. Well, so interestingly enough, like the comments that you have made, I just remember after or right before the holidays, I always have a conversation with my parents and patients. And I usually tell them, we should never make food our enemy. Because when we start making food the enemy, that's when we have this love-hate relationship. And everybody knows it's just like that bad girlfriend or boyfriend that you got that you know they wrong for you, but they feel so right at the time. This is a family place. But at the same time, I'm being serious. And so I always say, food is something that we celebrate. We have holidays around food, right? We have Thanksgiving that is all meant about food and football, if you're from the Midwest. And so one of the things that I always bring up is, one, food is not your enemy. Two, it's okay if you fall down. For a saint is just a sinner who fell down. That's right back up again. That's right. Amen. And that's what I always say. Because I usually say that because I know on the holidays, I'm going to go ham a little bit, just a little ham. And so I usually come back and I usually say, and I used to have in my office my plate of what I made. I would take pictures of what I made and I would place it up on the wall and I would let my patients see it because I wanted them to see exactly what Dr. Winters was doing and what he said. I wasn't also a patient, I was also a client. I wasn't the doctor, I was also a client type of deal. And that leads into one of the things that I talked about before with food is understanding, one, what are your triggers? What are the things that you know is going to be something that can lead you down a path that you don't want to go? So if that trigger is, for me, I know that trigger is definitely going to be either a cake or it's going to be, I love fried chicken, so it's going to be probably fried chicken too. So if I know if I'm going to make chicken, not to make it fried, because if I have fried chicken, well, I'm just going to keep on going. I might as well get the mac and cheese. I might as well go and get this. You said what?
Oh, I just said showing up.
So, I don't know.
Narrative around food.
Yes, so
therapy. That's what I'm saying.
yeah, I'll jump back to you. I'm gonna say AP. All right, so this is so important. It's one of the first things that I talk to with patients that come into me. I try to understand your relationship with food. So when you eat, when you have breakfast, when you have a snack, when you're eating during a movie, are you actually feeling hungry? Are you feeling bored? Are you just eating because it's something to do? Do you eat when you're sad? Do you eat when you're excited? Do you eat because that's just what you look forward to doing? Food is such a large part of our lives. And no one here, who hates food? Okay, I love food. And good food and cooked food and seasoned food, that's what we enjoy. Seasoned food. It's important. That's what we enjoy, right? And so when you think about your relationship with food, there are times when we're eating when we're hungry, but there are times when we're not hungry, right? We may have just eaten a meal, right? We just had lunch, we got back to our desk, we're at work, and all of a sudden now it's time to grab from the grab dish, right? We're having a candy, we have a little snack, I'm gonna get some chips, but you're not actually hungry because your stomach is full, you feel full. What's going on in your mind? And so it's understanding our behaviors, it's mindfulness around that. So understanding that when you're eating, sometimes we get so distracted. So how many of us eat dinner in front of the TV, living room, bedroom, something like that, right? And before you know it, the plate is done and your hunger left like halfway through that plate. And so it's understanding when you're having your meal to be in the moment, enjoying your meal. This tastes good. How am I feeling? Am I still hungry? Do I need to continue to eat this whole plate? And then also thinking about sometimes our behaviors. So if we're using food as our mental health counselor, right? We're not feeling well, we're depressed, we're going through stress at work, and what we're doing instead of accessing other resources is we're eating our way through our problems. And that's a whole different concept. We can't ignore that. And so understanding what the underlying issues are. Many times we have a psychiatrist that works in our clinic. And many times I'll have my patients, either I'm doing the counseling, I'm sending them to them as well, because there's so many different layers of how we interact with food that if we're not serious about it and we don't address it, we'll never get to the underlying problem. We'll never be able to overcome that issue.
I think Dr. Knight brings up an important point. There are times when we really do need to have a therapist involved, and so all of my patients that come to see me at Mass General Hospital, they see an obesity medicine physician like myself. They see a psychologist that specifies or specifically specializes in obesity, and then they see a dietitian. So we make up the team for that patient, and some of them may need a bariatric surgeon, and we're gonna let her do her thing with her phone over there. But there are different people that may need different things. There's actual real diagnoses. So one of the things I always ask every single patient, do you ever wake up in the middle of the night to get something to eat? Do you find that you wake up in the middle, when you wake up the next day that, wait a minute, there's some Oreo crumbs in your bed and you don't remember them being there? So those are actual pathologies. There is night-relating eating disorder and then night eating syndrome. Those are real things that actually need treatment. Some people have binge eating disorder. This means they feel a sense of a loss of control with eating. They cannot stop themselves when they start. That actually, we have medications that we can use to treat you, but the medication alone is usually not great. We want to have some counseling surrounding the work with that. Some people have eating disorders, bulimia, nervosa, for example. Most of those patients are of normal weight or actually have excess weight, but they binge and they purge, and maybe you do compensatory mechanisms such that they go and work out for 5 hours after they ate a whole cake or something like that. That's not good either. So the key thing is recognizing that there's sometimes when it's just us having a conversation about which things that we need to maybe change, and sometimes we need to escalate it and take it a step further and actually get the professionals. And for Dr. Knight and I, myself, when we're working with adults, or even when Ty and I are working with kids, we often will need someone that is trained specifically to do things like motivational interviewing, or we call cognitive behavioral therapy, to really undo some of these issues.
Thank you. So I think the biggest question, right, is how does somebody start, right? So today we're here, we're hearing all this stuff. We have Powerhouse here, we have Alma in the back, we're reading this stuff. You're like, today is the day. What's step one?
Okay, I'm grabbing for the mic. So I think there are a few key things that I want us to, that everyone should be doing, and we kind of think of this as the base of the pyramid when we're talking to patients that have overweight or obesity. So we want to look at the quality of the diet. We talked about, and I'm going to say it again, lean protein, whole grains, fruits and vegetables being predominant in our diet. We do want to have at least 150 minutes of moderate intensity physical activity per week, at least. That's the minimum. Most of us that carry excess weight actually need more than that. So that means your hair is not going to look cute, and it's okay. You're going to be sweating. You need to be sweating. You need to be exerting yourself in such a way that's sustainable. 150 minutes would be like 5 days, 30 minutes, consistently, forever, hopefully more. So that's important. We need to look at the quality and duration of our sleep. So sleep plays a large role in how our body regulates weight. And one of the things that we often do is have poor sleep hygiene. We're not getting adequate sleep. We have our TVs on in our room. I will not let, my husband will probably be watching the TV because I'm not there tonight, but he knows to not turn on the TV in our room because you're not supposed to have any screen time. He knows. any screen time of any kind, whether it's your phone, whether it's your iPad or anything, because that disrupts how the brain sees the sleep-wake cycle. So circadian rhythm, whether or not you're a night shift worker versus a day shift worker, plays a role in whether or not you might have excess weight. The body wants to be awake when it's bright outside and wants to be asleep when it's dark outside. And when we deviate from that, the body tries to defend or hold on to more weight. It sees that as something that's abnormal. So those are kind of some of the key things that I have everyone think about, right? Diet quality, physical activity, sleep, and the other big thing that I would think that's kind of at the base of that pyramid is stress. Now, as Black folk, we know that we have stress that by far exceeds that of our other persons that are here in this United States. And so often that's something that we have to talk about amongst ourselves, but it's real. And actually studies have shown that, for example, internalizing racism in and of itself can lead to more stress, which leads to more weight. And it's something that we can't change. I can't change the fact that all of us that are sitting up here are Black Americans. It is what it is. And so we have a different level of stress in our environment. And so how are we going to mitigate that stress? For me, they will know I will do a workout in a hot second. And I did a hour-long kickboxing workout this morning, and I was angry with people that had been racist towards me and other things, and let me tell you, they all got beaten up, but they don't know it. They don't know. That's the thing, is they don't know, but they have been bloodied up. Let me tell you. So the thing is, it's finding out what you need to do to relieve that stress, right? And some of it we can't get rid of. Some of it is just going to come into your life, and you're going to be like, oh. But figure out what that mechanism is, and I would say that those are the key things, right? Diet quality, sleep, stress, and physical activity. Those are the key things. Now, beyond that, we may need to escalate therapy. Maybe you need medication. Maybe you need therapy. Maybe you need weight loss surgery. It's fine. It's okay. And don't see yourself as a failure if you need those tools. It's about using the right tool for the size of the problem. If someone has severe obesity, and this is how I explained it in Boston because it snows a lot, and if it snows and we get 14 inches of snow within an 8-hour period, am I going to go scoop the snow up with a teaspoon? That's ridiculous, right? I'm never going to get home, and I'd be still at home instead of here where I'm supposed to be. What you want to use is the right size tool, right? So I'm going to need a bulldozer to kind of push that snow out of the way so I can get home, so I can go home and come back to see my patients. When I think about weight loss surgery, it's using that tool to treat the severity of the problem. And it's not a failure. It just means that we need an additional tool. And we don't ever say that if someone gets cancer, oh, we're not going to use that tool. They should just eat less and exercise more, because if they did, their cancer wouldn't be here. That's ridiculous, but that's how we think about obesity.
I know you have. I can see Dr. Knight is ready to go. One of the things, especially for pediatric patients, that I usually would say when parents would come in and we have this conversation, the first thing that I would tell you right now for advice would be, if that's you, if you feel like you need to have help with your weight, then I usually would say, first, go and see your physician. If you don't have one, I recommend that you go and get one, because they can definitely be a partner. The other thing that I would say that I have my patients do is, we go through a list. And a list is everything that the patient feels, or the parent also feels, that can be contributing to an issue that they may have with weight. When we go through that list, I normally will say, okay, what is the one thing you think that you can change on this list? I have a tendency to go first on the slower side because I need to get buy-in. And if I feel that one of the two, and in pediatrics, which we can tell you, it's always two patients that we're treating, not just one. We're always treating the parent and we're treating the child as well. So if I can get buy-in by that one single thing that they can seem to hold on to for at least a month, and I may even have them come back depending on the dosage that I need to give them, which would be maybe 2 weeks they come back, or a week. And if they can hold on to that one habit, we're trying to now add on new habits and see how that goes. So that's usually how I would say is, create a list of all the things that you think. It may be completely not the right thing. You may say, like, oh, you know what? It's because I wore these earrings this day. That's the reason why my weight is so high. Okay, if that's what you think it is, then that's fine. Then don't wear that earring no more. And then let's see how it goes. But at least you got by.
I would say, I think, okay. I think one of the things is that understanding weight loss is a journey, right? Weight management is a journey. And I don't call our claim the weight loss claim, it's weight management, because it's not first you're losing, you're trying to maintain, there's always going to be ups and downs. It's a journey. And so the first thing is being ready for that journey. You gotta be honest with yourself. It takes time, it takes commitment, because our bodies oftentimes are not in our corner in trying to help us to lose weight. And I think that's important, because a lot of people have been told growing up, we've been told by society that the reason they have excess weight is because of lack of willpower, that you are just not committed. And because I don't have excess weight, I know it's because I make the right choices and you make the wrong choices. That's not how it works. And so that is the first thing to understand. It's going to be a journey. So you have to be ready for it. So in my primary care patients, I'll have patients who come to me and I'll say, you know, are we ready to talk about the weight? Not ready right now, Dr. Knight? Okay, we'll talk about it next time. Because they have to be ready. I can talk to you for 30 minutes about everything that I want you to do. If you're not mentally ready to do that, then it's not going to be successful. You're going to be frustrated. I'm going to be frustrated. We're wasting each other's time. So the first thing is being realistic with yourself. Maybe you're having a lot of issues on the job. You're dealing with some issues at home, trying to get these things paid. You got to be at the right place to get ready to move into this. And then when you are ready, you say, okay, right now, Dr. Knight, I'm ready. I'm ready to take this seriously and go on this journey. My bags are packed. I done put the kids up. You know, I'm ready to go on the journey. Think about it like a trip. And so when you're ready, then it's setting realistic goals to get you to that place. So for example, we talked about 150 minutes of moderate physical activity per week. If you're not doing anything right now, the idea is not that you're gonna do 150 minutes next week, okay? That's number one. So if I can get you off the couch, if I can get you walking 15 minutes a day, I'm serious, like simple things. That's gonna help me get you to that goal, okay? I have patients who come in, they're telling me they're drinking, you know, 2 16-ounce sodas every day. They're eating this, they're doing that. So obviously the doctor's gonna tell you the first thing you need to do is cut the sodas, period, right? That may work for some people, but it doesn't work for everybody. And we continuously decrease. I say, okay, let's try 1.5 of those. Let's bring it down to 1. We're just gonna do it on Wednesdays. We're just gonna do it on Sundays. And this is some gradually, time after time, and eventually we get to the point where you're not doing it anymore. So if you're having cake every night, we're gonna say, okay, let's bring that back. Let's do the cake on Friday nights, on Sunday night. You know, let's start moving in that direction. And that's how it is, because when you start making these changes, your body is also making changes to maintain the weight. So when we talk about weight, one of the things that I know Fatima has a whole spiel on this is what we understand about how our bodies maintain our weight. We will go for months at the same weight. We may go up and down 5 pounds, but we'll be around the same. So last year, this year, we're around the same. How many nights have you not eaten dinner? You had a large dinner, you went to a party, and you get on the scale, you're the same weight, right? So it can't just be what you're eating and what you're exercising, energy you're expending. We all have what we call a set point, okay? It's kind of like a thermostat when it comes to your weight. And your body is going to manage that. We think about our hunger, we think about when we feel full. It's not just having food in your stomach. We have hormones in our bodies that tell us that we're hungry, that tell us that we are not feeling full. Our metabolism is also under regulation. So you're in the gym, you're doing this, you lost your first 5 pounds and you feel excited, and then the second 5 pounds is twice as hard, and by the third 5 pounds you're back to where you started, right? Because our bodies now are changing to keep up with what we're doing. And so that's frustrating. And so we diet, and then we're not successful, and we're like, you know what, I'm not doing this anymore because obviously I'm doing something wrong. But the idea is you're doing the right thing, but you have to understand how your body's going to react to that. And so by working with someone who, like us, have the training in it, we can design a plan to overcome your body's pull to get you back to that weight. And what is that going to take? Specific nutritional changes about how many of the nutrients that you have in your diet, specific changes in physical activity, sometimes medication, sometimes surgery for certain patients, but it's different for everybody. So it's understanding it's not just your willpower. You're not just eating because, I don't know why, I just want to eat more. I just want to be heavier. No one's coming and no one's saying that. It's what you're feeling. I feel hungry. That's why I'm eating. I'm hungry. I'm not full yet. That's why I'm ordering a larger meal. So it's understanding that that's natural. How do we overcome that? And that's the key to weight management.
So the other thing that I wanted to talk about is to your point of, if you stand 2 people next to each other, one's thinner, one's heavier, the assumption would be that heavier person isn't trying and the thinner person is, right? Can you talk to us a little bit about the genetics involved, particularly folks of African descent, and what the, body types, how that plays a role as well.
So, when we think about persons, we make visual judgments about them, right? So if someone's leaner, we assume that we make the assumption that they're doing all the right things. But what it is that their body is just defending a lower set point. I want us to think of this as having different size gas tanks, right? A person that might have severe obesity has the gas tank the size of like an army tank, right? And maybe that very lean person has the gas tank the size of like a Prius, I don't know, like a really small car. What happens is the brain does whatever it can to make sure the gas tank is full. So let's say you've gotten to 350 pounds. The brain knows that it was 350 pounds. And no matter what you do, so do you guys remember the TV show The Biggest Loser, right? So those patients would lose a lot of weight. 96% of them regained all of their weight. 96%. That was published in this lovely journal called Obesity. And what happens is that when you lose weight, your resting metabolic rate drops, okay? So the average, like how much they would burn, once they lost that weight, the average for those individuals dropped to 700 kilocalories a day, which means that they ate 701 calories, which I did today. You guys probably did that this morning. He said this morning. Your body fights to come back. It does whatever it can. So it holds on to whatever it can to get us back to that set point. So when we talk about sometimes needing more aggressive measures, there are things that we can do to help overcome that set point. Maybe it's medications, but if we go on medications, you guys, for weight management, it is a long-term commitment to those medications. Because if I give you a medication that helps you lose weight and I take away the medication, what happens? You regain the weight, because those medications act on the way my brain sees weight to drop my weight to a certain point. I have doctors that come all from the Harvard hospitals, right? And they're like, well, Dr. Stanford, well, I'm taking care of this patient with you, and it looks like she's lost the weight. When were you planning on stopping her medicines? And I respond to them very nicely. According to the physiology of the body, I will continue them on these medications indefinitely. This is why, that's why I'm still continuing to see them. So the whole point is that it's recognizing that it is so complex, and we should not make judgments when we see someone coming towards us that happens to be leaner versus someone that happens to carry more excess weight. Maybe the lean person has a history of substance abuse. Maybe that's how they're leaner. Maybe they actually are leaner just because of the genetics behind who they are. It doesn't mean that they're better than this person that carries the excess weight. I just need to do a little bit more to get that person back to normal. Now, what we do know about us as persons of African descent is that there are certain things in our biology that cause us to carry weight in different areas. So when we look at us compared to white individuals, we are more likely to carry our weight in the hip, buttock, and thigh regions. That's, if you take our ancestors in Africa and you look at persons here in the US, that is consistent from children all the way through adults. In both black men and women compared to white men and women, we carry our weight differently. They tend to carry their weight more viscerally, which means around the organs in the central region, in the abdominal region, more so than we will. Now, not that we don't carry it there, but we are less likely to carry some of our fat there. We also are likely to have, on average, a slightly higher body mass index when all things are controlled for. So if you look at a lean black woman and compare that to a lean white woman, you might still say, oh, that black woman tends to have slightly more adipose. Adipose means fat. And that's just part of our genetic makeup. Now, notice I said slightly more. When we have a significant more of excess, then that's problematic. We need to deal with that. So it's important for us to recognize that some of it's genetic, but we have to recognize what part of it is something that we need to work on. Never mind.
But I think it's so important about where we carry the weight is important. Because when we think about, again, it's not just how you look. My concern is, how is this affecting your health? And so for many people, you look at the BMI scale. How many people looked at the BMI scale to find their ideal weight? right? So you see the BMI chart in the office, say, well, I'm 5'4", so what do I need to be? I need to be 130. I'm not dealing with this, right? Because I'm not going to be 130, right? So it's like, how do those numbers really play a role? When we think about the BMI charts, it's really a first step for providers to understand where do you need to be to really decrease the risk of health issues. And what we understand, and Dr. Cody Stanford, you can look her up on the internet and find all of this information, is that depending on our ethnic background, that number may be different, right? And so for someone who is African American descent, for example, a woman, she may not need to be 24, BMI 24, to avoid a lot of these health issues. There may be a little bit more flexibility. So it's understanding a healthy weight for you. And so when a patient always comes in and says, Doc, what's a healthy weight for me? That's a complex question, because I may not need for you to lose 70 pounds to see a health benefit. What we know is that 5 to 10% of total body weight loss can lead to health benefit in your blood pressure, sugar control, cholesterol, you name it. So when you think about that, so if you are 250 pounds, just losing up to 25 pounds can be a huge benefit. And so sometimes that's a more realistic goal, initial goal for many patients. And so it's talking about that, thinking about where we're carrying the weight. Are we carrying it more in the abdominal area? For many of our patients, especially those who have BMIs less than 35, doing a waist circumference, for example, is a lot more indicative of how the weight may increase your risk for health effects. So, for example, someone who's in the gym and has a lot of muscle, so a bodybuilder, their BMI is going to be very high. And that's because they have the muscle mass. But if I do a waist circumference, that waist is in. And so that's telling me, their risk for health issues is not the same. And so when we think about that, it's not just what it looks like on the scale. It's about how much of this is muscle mass, how much of this is fat mass, what is my waist circumference, what's my family history, what am I eating, what's my physical activity. There's so many different components, and what's my ethnic background. And so anyone who's just telling you, well, your BMI is 30, so that means you're going to get diabetes, get in the gym, stop eating all that stuff, and that's the end of the conversation, that's not the provider for you. And that's not the provider you need to go to talk to you about weight. Maybe they're good for something else, but for weight, that's not the one. We need to have a complex conversation, and you can't just stop there. Well, what does that mean? Well, let's go through it. If you're not asking me what I had for dinner last night, what I eat for lunch, what I eat for breakfast, then we're not having a real conversation about my weight. You have to understand where I come from. You have to understand what I'm eating. You have to understand my weight history, how long I've had this weight, how many times it's gone up or down, for us to really have an effective conversation and draft an effective plan that's going to give me success and not get me frustrated and back on the same track we've been down every January, new year, new me, right? With the same old plan, okay? It's gonna be the same year, it's new year, same you, wrong plan, okay? So that's the understanding.
I was just going back to body characteristics and genetic makeup. We hear in the Black community all the time, she's just big bone. Does bone density play a part in?
I want to answer this. Okay, you guys. This idea of it being big bones is, okay, so our bones technically have a slight more density if you look at them under a functional MRI, but that's not the issue. When we carry more excess weight, it actually affects our bone quality. So if I were to go into a total knee replacement where I actually cut down and look at your knee, your bones are actually smaller than someone that's leaner, that's doing like weightlifting or weight-bearing activity. So kind of a fallacy, wrong, basically. That's what. Sorry.
No, that was a great question. One of the things I was also going to say too, just kind of going on to like even bone density, when we look at different things, like when we go to the physician, and all four of us can tell you, when we draw blood, and we draw like things like a complete blood count, and we draw things like a comprehensive metabolic panel, which tells us like anything from your renal function to your, I should say kidney function, to kidney function, all those different things, right? Because of our ethnicity, we may have different values and different levels that we may see. So case in point, one of the things that you will notice is there's a test that's called the hemoglobin A1C. So with the hemoglobin A1C, that usually will tells us what is the average blood sugar level over a 3-month period. Well, there may be some individuals that may have a lower hemoglobin level, which is part of the red blood cells that helps us. Yeah, so but the thing is that we may have something that a lot of us carry, which is a certain trait or maybe a certain change in our hemoglobin that makes our hemoglobin low. So it makes it look like our hemoglobin A1C is higher than what it really should be. So it make it look like our glucose is really high. But if we didn't know to look for the fact that we may have a little lower hemoglobin, that may be a huge difference. So not only are we looking at body habits or like the way that our waist circumference is when we're looking at those different measurements, but we're also looking at those blood levels too and saying like, you may be a little bit higher. We can have a higher kidney function level, a little bit higher than most, and it may not affect us as much as others, even though we know kidneys is one of the things that a lot of people in our communities suffer from with kidney disease.
All right, were there any other, go ahead, get to the other question?
What are doctors doing to help like dietitians in the school? I think this is great and so informative, and I'm so glad I'm here. But there are children, like for example, my granddaughters were in the Girl Scouts this summer, and they brought home what they were eating for breakfast, lunch, and snack. And when I looked, it was bologna, it was fatty turkey, it was nothing that was nutritional. So we could say, well, we can start at home. We know as a people, we need to change the way we eat. I'm not saying that we can't eat mac and cheese, but maybe cut back and use skim milk or whatever. But what is being done in the school systems, because the kids are eating breakfast there, they're eating snacks there, they're eating lunch there, or not getting things healthy. So what, nutritional wise, for the kids in school, that you could tell them, okay, I'll let you talk.
No. The funny thing is, and I'll tell you this, and I think all of us do the same thing. Sometimes we are so in the habit of getting ready to respond to a patient, and we never just stop, sit down, and just listen to you. So I wanted to make sure you got everything out that you wanted to talk about, so I can make sure I can respond appropriately.
And then there's some, then they go home, and there's some people that, and for that program, we was paying for them to go, so they should have had that lunch for us, I'm concerned. Even if we weren't paying. But the other part is for parents that don't have the money. You can say you need to change this, like one of you or all of you hit the nail on the head. I'm not telling you to change, but how can we kind of switch it up? When they go to the store, they can only get what's affordable. And a lot of times that's not the good foods.
Doing it all. No, we're coordinated. No, seriously, that is a very valid question. And it's something as pediatricians, we deal with on a consistent basis. And a lot of times we have not the most power. The reason why is it's based off of a couple of things. It's first based off of what the state is going to give your school district. And as you and I both know, most minority students live in school districts that get the least amount of funding based off of property tax, right? However, when that happens, then the school district will have so much money and so much funding to be able to have it. They may not even have a school registered dietitian, or they may have one that's supposed to take care of the whole entire school district. And so the thing that happens is that you look at a form. So case in point, I had a patient that came in, and I said, what are you eating for breakfast? And they said, well, we get orange juice and we get muffins. Well, what did they consider? Why did they say that you can have muffins? Because they were blueberry muffins, so they had some blueberries in them, so that was the fruit. And then they had the milk, and then they had the whole grain muffins, right? But that's how the school districts can get away with it. And the thing is that now you have school districts that are having competing individuals to be able to provide the funding to provide the school lunches or the school breakfasts. So if I can bid a lower bid for you, because I know I can get these muffins, these Hostess muffins, for $1 versus giving you an apple, which can be sometimes, and let's face it, the bodegas around here, $1, which one am I going to get? Which one am I going to give you? And I can divvy up those different things. And it's all about the process. And I'm not trying to get political, but that's where the power of voting comes from, because that's how you're able to change those school districts. And as a pediatrician, a lot of times my hand is tied, and I have to keep going on with this. The reason why I say that is because when I was in Columbus, Ohio is, for that area, it's the same size as the city of Chicago in terms of mass, but it has the least amount of people, maybe like a million people at best. But what was happening is I was seeing all of the kids that were coming in, minority kids, that were not being able to afford to go to the YMCA, able to afford to go to Boys and Girls Club. You get 4 good months out of the year, and that's God helping if it don't rain in the state of Ohio. Other than that, you're stuck in an apartment building. You're stuck in a trailer park home. You're stuck in all of these different things. There's so many different factors that are playing against you. And I got angry. I mean, I was just angry because I said, I cannot keep going on with this and not doing something. So what I wound up doing is, I said, I'm just going to take it out of my own money. I went and bought a machine, bought a little speaker. I went to my boss and I said, I want to start a dance class for the kids, just to give them something to do. And so when I wound up doing that, I took just the same type of space. I cleared out all of the tables, all of the chairs, and I asked for a few volunteers to come to help me, and I had all of the families come. I had 25 families show up that first day. And it blew up. And they were eager for it. And as a pediatrician, as physicians, we get, just like Dr. Gaines, she gets frustrated seeing this on a day-to-day basis. What can we do? And these are the things that we try to do. But the one thing that I will say is, as a people, we really need to make sure that we get together and we remember our political power.
All right.
And just to respond to how we can buy foods if we're resource limited, I am a huge fan of frozen vegetables. What people don't realize is that you do not have to go to Whole Foods and your food goes bad in like a few days. You can buy a whole bag of whole leaf spinach for usually $1.99, 6 servings in that bag. People don't think about this. So when we were doing our program with WIC in Georgia, and specifically in Atlanta, we would teach people how to use food stamps to buy healthy foods. A lot of it is shifting how we think about what we're getting to eat. You know, but we can do it. And I think that these are things that we don't think about when we're thinking about the use of like frozen fruits and vegetables. I can tell you that's how I got through medical school and residency and everything else, and still how I get through most of the days, because I don't have time to do all of this other stuff. I can get my frozen vegetables, they get delivered to my house, and then I can prepare them, and they're frozen when they're most ripe and when they're freshest, okay? So that's something that we can do. It's just something that we don't think about. So that's just my response to that. But we want to take more questions. Yes.
I'd like to say I appreciate the knowledge and sharing.
Yeah.
I'm under the impression that if metabolism increases, that your weight will kind of go down. I don't know if that's true or not.
Let me say that. So that over.
As your metabolism increases. Okay.
Okay.
Yeah. And the other thing, the tie-in between BMI and pounds, because most people look at pounds. They don't look at BMI.
Okay. So first of all, metabolism. So when we think about metabolism increasing, we basically are. Let's say the 4 of us up here, we have our resting metabolic rate. So I can't really change it. It's just kind of what I have, and it can change over time such that my metabolism may decrease as I age, and so we can see weight begin to increase. But it's kind of something you're just given, right? Like it just is what it is. I can do things to modify how my body responds by looking at diet quality. I can add a medication that might change my metabolism, but metabolism is kind of a genetic blueprint. This is just what you're given, and there are certain things we can do within that, but it doesn't, it's just kind of what it is. So what I do in my office is I do what's called a med gym, where we kind of put this canopy over your head and you kind of breathe into this machine for 20 minutes, and I can say, Dr. Knight, your resting metabolic rate is 2,000 calories, which means that at rest, if he does nothing else, he'll burn 2,000 calories. That may be high for, what I would predict, but I've gotten that real data to tell me. I may do the same to Dr. Winters over here, and I do his, and it says he's 2,600. He's taller, maybe, you know, I expect more, but we can do these equations to predict what the metabolic rate is, but that's a more accurate assessment, but that doesn't, we can't make it go up. Like, you can't just make it go up. Now, the reason why we look at body mass index is that we're all, even just if you just look at the three of us, we're all different heights, which means that 250 pounds for him would be very different than 250 pounds for me. He's 6'6", I'm 5'6", so a whole foot shorter. I don't know how tall you are, Dr. Knight, but the whole point is that I have to look at it and I have to take into account the height and the weight portion of things. So someone that's taller, I wouldn't expect them to be the same weight as someone 5'6" and 6'6". You wouldn't expect them to be the same weight. You seem like you're taller than this lovely lady sitting to your left, right? So the idea is that I wouldn't expect you guys to have the same weight, but I could look at your BMI and kind of give some, look at it more equal. Does that make sense? So I know it sounds like a foreign concept, and as Dr. Knight mentioned earlier, it's just something that we use as kind of like a rough number to kind of give us a sense of where you are, and that it's not the end all be all. We have to pay attention to more factors, but the BMI gives us some idea of like what ballpark we're in.
So therefore, if I see one, does that mean I should stick, that's gonna be the one that I should stick to, whatever the schedule is, the BMI?
So yeah, since you're not going to get taller, so your BMI, we want to keep your BMI on average definitely below 30 out of obesity, right? And so whatever your height and weight is, you can look at, you can do what's called, you can just Google, right, BMI calculator, put in your height and weight, and it'll give you a number, okay? And it'll tell you where you are. And then our goal is to always try to bring you out of obesity. I don't fixate on that you have to get to a certain number, like Dr. Knight said. It's not like you have to get to this number on the scale. But you know, if we can get you out of obesity, that's something that I think we strive towards.
Can I do a quick follow-up to that, because I think this is where you're going to is, so if you have your resting metabolic rate, like your 2,000 calories, your 2,600 calories, can you do anything to increase that? Or is that where working out gives you the extra like where do you, I think that's also where they were going with that.
So I mean, so again, resting metabolic rate, what we think about metabolism, this is what you're burning by doing nothing. You're just sitting here, you're just living, you're just breathing. Your body, by moving and your organs are working, you're burning calories, right? So whatever that number is, that's what you got for the day. So say it's 700, that's how much you burn. So anything above that is what you're gonna be in your energy expenditure. So your physical activity, being in the gym, walking around, getting your 10,000 steps in, that's adding to what your body's already doing. So if you know that you're saying, well, I'm taking in 1,500 calories, I'm trying to, above that, my metabolic rate 700, then you have to add on top of that 700 so you can continue to make sure you're not taking in more than you're expending. That's a very simple way. It's not that simple one-to-one, but that's how you think about it. So when you see those pills behind the counter at the grocery store that says it's going to increase your metabolism, probably not. Very difficult to do that. Now what we do know is that there's some certain types of muscle that you build, like your lean muscle mass, that can have a large effect with your metabolism. So there are some ways to improve that, but on average, as we get older, the metabolism is going to go down. And then also understanding your body can also affect that, because like Dr. Cody Stanford was saying, when we see large amounts of weight loss, especially in a short amount of time, your body will drop that resting metabolic rate as well. So it's more likely that it's going to go down than it's going to go up. So that's why staying, how much energy expenditure you're doing, and as we lose weight, oftentimes having to do more in the gym to maintain that weight, that's the reality that we're dealing with.
Within the medical field, what do you consider a person being obese? Is it by weight, height, or body mass? In your definition, what do you consider obese?
Yeah, so it's height. So remember, BMI is height and weight together. You use your height and your weight to calculate it. So if I'm 5'9", right, I'd say I'm 5'9", my weight is this. I put it in the calculator, it tells me what my BMI is. On paper, a BMI that is greater than 29.999 is obesity, right? So that's what it is on paper. So it's a medical definition. A lot of times in our mind, when we think obesity, we're thinking like 400, 500 pounds. A lot of times my patients come in, I say, anyone in your family is obese? Like, no, nobody's really obese, maybe a little heavy, but not. So it's how when we think obese, we're thinking my 600 pound line, we thinking that. But it's a medical term, and that's why I don't use the term that often in my clinic, because I use excess weight. I say other things because the way that we think about it is different. But the medical definition is when you calculate, you put in your height, you put in your weight. If that number is 30 or above, then that's obesity for adults.
Can I just say, in terms of even for adults or for kids, one of the things is that I'm happy that Dr. Knight brought this up and you brought this question up too, which was what is technically considered to be obesity or the diagnosis of obesity. And the reason why I say that is because when we look at somebody, a lot of times we will look and see like, oh, what does people like, are you overweight, are you a little heavy, or blah, blah, blah. The thing is that there was a research study that was done, like in Canada as well as in Kentucky, that looked to see both for patients as well as for doctors. If you can look at somebody and tell if they are considered to be overweight, obese, or normal weight, can you imagine how many people could tell appropriately? 18%. And the reason why is because if you look now, roughly, if you think about for children, I guess that's where I'm at right now. So you have a good 12% of the population in the US that is technically for our children that are considered to be obese. It's 12 million. 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 Probably. See how she tried? But no, I like it. No, it's 12.1 million. Yeah, it's 12.1 million. All right. So anyway, needless to say, but what happened is that if you think about that, if you're looking at the schoolyard right there, even in now this one I know for sure, 55% in Newark alone for our pediatric patients are considered to be either overweight or obese. So then if you go in the schoolyard, at least 1 out of 2 of the kids are going to technically considered to be overweight or obese. So then your perception changes, right? So your perception of what you think is considered to be normal has completely changed. And so that's the reason why our visual, the way that we can see people and assess people is changed, because we're going off of this new normal now.
You had a question in the back, right? Did you have your hand up?
I was just going to ask if you could just debunk some of the myths around diets and diabetes. I know that's an issue that's prevalent in the Black community, and we hear all the time, hey, if I just cut this sugar out of my coffee, I won't have diabetes, or I won't eat this cake, I won't have to worry about that. So could you just please explain the correlation between the two and maybe debunk some of the myths that some of us
I was just going to lead into it by saying, no, eating sugar does not cause diabetes, but I will let them break it down for you guys.
So when we think about how the body regulates sugar, a lot of that's happening in the pancreas, right? And so I like to think of it in terms of how our bodies, you know, like let's say someone that does not have diabetes, their pancreas is working to keep their body normal. So think about it like an elliptical machine. They're just on cruise control or whatever. So now we can develop insulin resistance. Insulin means that our body's no longer recognizing the insulin that's on board, and so it's working really hard to try to pump out enough insulin to keep our blood sugar normal. And when it kind of burns out, that's when we start giving you insulin, because your body is no longer producing the amount of insulin it needs to keep your blood sugar normal. Now, when we're looking at diabetes itself, the reason why we cut out what we call concentrated sweets or sugars is because that added sugar makes it even harder for our bodies, when it's still producing insulin, to put out enough insulin to keep our sugars where it needs to be. That's the best way I can think of it.
Yeah, I'm going to take it back a little bit further,
Oh,
right?
sorry, I apologize.
So so again, back to the 3 types of things that makes our food. So proteins, fats, carbohydrates. So carbohydrates are not just things that are sweet. So when we talk about our bread, our pastas, even vegetables, fruits, all of those things are carbohydrates. Our body turns all of that into a simple sugar called glucose, okay? So it don't matter what it is, if it's a carbohydrate, your body is eventually turning it into sugar, okay? Normal person is able to process that sugar using a hormone called insulin, okay? We all make insulin. And our insulin works so we can process the sugar, we move on with our lives. Now, the challenge is for many people, either genetically, because of weight, a variety of things, we start becoming resistant to the insulin, meaning we have to make more of that insulin to do the same job. So you follow me? Okay. So you eat the carbohydrate, you need the insulin to process it. As I become resistant, I'm making more and more. And then I get to a ceiling where I cannot make any more. And as that resistance continues to go, then the sugar levels start creeping up. So I'm not processing all the sugar anymore. So now it's staying in my bloodstream. So now I'm in pre-diabetes. And then it keeps going up and I'm in diabetes. And then over time, your pancreas gets tired because it's pumping out all this insulin, burns out, and then now I'm having to take pills, I'm having to take insulin because I'm not making enough insulin anymore, or the insulin I'm making is not enough. So that's the connection. A lot of times when we put on excess weight, we become resistant to the hormones that process our carbohydrates. And so for someone who doesn't have insulin resistance, doesn't have this issue, I can eat a donut every morning. My body's processing the sugar. I'm good.
Right.
When I cannot process the sugar anymore, that's when I have diabetes. So if I'm already diagnosed with diabetes, at this point, that piece of white bread, that bowl of pasta that I'm turning into sugar, I cannot process it like a normal person. And so I'm going to continue to have issues with high blood sugar. And so it's understanding that level. These are conversations that we have. If your doctor is not explaining it to you like this,
Right.
that's the wrong place. Okay? So again, you have to have those conversations, because if you don't understand what's going on with your body, there's no way you can effectively manage your health. You have to be able to break it down to that level. And if the provider's not doing it, they need to have a dietitian, they need to have a nurse, somebody who can explain that to you, because you have to understand how these things are working.
I just wanted to confirm. So that being said, though, losing some of that weight can get your insulin resistance, decrease the insulin resistance, correct? Right. Okay, yes.
So, and I don't want to use the word diet because I like
Diet is in the word diet.
Cody, Dr. Cody Stanford.
I go by Dr. Stanford.
Dr. Stanford, yeah, diet is in the word diet.
Yeah.
But so from a weight management standpoint, one of the things that I've had an issue with regards to carbohydrates, as I've gotten more mature. I don't want to say old.
More mature. I like that.
Right. So.
That's what I call myself too.
Yeah. Hey. So, you think about it. Because I had a conversation with my doctor, and he was like, "Okay, so what are you eating?" So I said, "Okay, well, some mornings I may have eggs and toast. All right, and then for lunch I'll have a sandwich. All right, so that's 4 slices of bread, and then at night I might have spaghetti. All right, so, he got me to really think about the carbohydrates that I may consume in one day, and I'm saying, okay, so from a weight management standpoint, what do you do if you're accustomed to having, and I don't eat toast every day, but maybe 3 days a week, I like my home fries, my eggs, and my toast, and then I'll have a sandwich for lunch, and then, I may have pasta. So, and then I looked at wraps, and wraps are not always better for you from a carbohydrate standpoint.
Right.
It's a myth. And it wasn't until I started reading these ingredients, and one thing I will say, start reading the ingredients on these packages. All right? I'm certain they'll touch on it, but start reading the ingredients, because it's been an eye-opening experience looking at the ingredients and saying, okay, well, baby, we'll start eating wraps instead of bread. Then I'm looking at the wraps and I'm like, I'm better off eating the bread.
It's more, yeah. I literally just said that to them on our call preparing for this, that because I'm watching my carbs, just because I have figured out for me, cutting calories doesn't do it. I have to cut down to a certain amount of carbs. That Subway, I was doing ER shifts in this very small town, that the only fast food option that I could eat that's not fried or meat or pork is Subway. So I am very well versed now with Subway's nutrition facts. And so I looked one day and I was like, so I could have a 6-inch Italian, like the Italian bread, the normal Italian sub, or I could have the wrap, but the wrap was actually 15 grams of carbs more than just the thick bread, right? So, but in our minds, we're thinking it's thin, right? So it can't have a lot of carbs. So yeah, I agree with you. Once you start really looking, even salad dressings, things that you think aren't even sweet, to your point, have so much carbs. And again, I think the take home is, like, if you, yes, your body can burn a certain amount of carbohydrates, right, in whatever you're doing, but then once you're over that amount, that stuff becomes sugar if you're not burning it. So.
And then understanding that carbohydrates are not an issue for everybody.
Right.
For most people, and of our ethnic background that are dealing with excess weight, they are. And so with patients, I actually screen for insulin resistance, not just pre-diabetes. Your A1C could be completely normal, and I'm seeing signs of insulin resistance. Sometimes we see the dark coloration behind the neck or on the underarms. Those are skin signs that insulin resistance may be present. So if you're dealing with insulin resistance, then yes, we need to reduce the carbohydrates. Also understanding all carbohydrates are not the same. So one of them, no, we don't got time. But if you go on Google, look at like glycemic index or things like that. That really shows it. So the simple carbohydrates, the white ones, usually the white bread, bagels, pretzels, things like that, our bodies turn that to sugar very quickly. And so you have a spike in the sugar, a spike in the insulin, and that takes us down the road to excess weight gain versus our whole grains or the carbohydrates that take a longer time to break down. So the fruits are, like vegetables are carbohydrates, but they're so low on the glycemic index, it just doesn't have the same effect. So it's not just looking at the carbohydrates on the labels, that's number one. So definitely nutrition facts, looking at the carbohydrates on the label, but then understanding how different carbs affect you if the carbs are an issue. So that's why it's so important to have a comprehensive discussion. I'm spending 30 plus minutes with a patient when I first meet them to understand what they're doing, what their medical history is. We're often doing blood work, okay, to understand how you're processing, and then I'm gonna tell you the dietary strategy. If I'm telling you a dietary strategy and I've only talked to you for 5 minutes, that's probably not the strategy for you because I don't even understand you. I don't even know your last name at this point, right? So we got to talk. I got to know where you're from. I got to know your medical history. And then if carbohydrates are the issue for you, then what is your goal? How much should you be having per day? What types of carbohydrates? So it's a long conversation, but that's kind of the idea.
Wow, okay.
You know you're going to have a line outside your office. There's going to be a bus ride.
Oh, yeah.
Yes.
I have a couple of questions.
Okay, question one. We don't want to lose control. We want to make sure we're going to start with question one so we don't get lost.
Okay, I've been diagnosed with prediabetes.
Okay.
It's obvious that I'm not overweight. Okay.
Okay, so no, I'm going to stop you there. So pre-diabetes does not always correspond with having excess weight.
Right.
I think that we put those together, but different people have a family history. Like if you have a strong family history of type 2 diabetes and everyone's lean, obviously that wasn't what caused your body to move into an area where your body isn't processing
Because
sugar.
remember, you have a nature and nurture thing, right? So you have something that's internally that's going to control why you can get it, and then things that you're doing outside that can control it.
So, okay. Once I was diagnosed with that, right? I removed a lot of stuff from the diet, right? I've never been. The most I've ever weighed in my entire life is 131 pounds, and that's around 9 months pregnant. Okay, so it's easy for me to drop weight. So now when I started taking out things, you know, like you can't eat the whole muffin, you either eat a half or a quarter. You can't eat this, you gotta eat it. So now, I've never been large, so now you start losing weight. So now I'm trying to balance to get, because, you know, between the nutritionist and my medical doctor and I forgot what you call them. Endocrinologist, okay? Between the three of them, right? They're trying to get the body mass back up, right? At least to the 120, 25. No. And I'm like 5'6". Right. Okay, so they want me to increase the calories, right? But then you gotta, like I had to learn how to pair carbs. If you eat this carb or this starch, you know, because like there's a lot of starchy vegetables. Right. I had to learn how to pair it with a protein. Mm-hmm. If I have an apple, I always have cheese. If I have this, I have that. so that you don't get this spike like this, okay? But now, it's constantly thinking about eating, and it's constantly eating to get the calories up. So it's like, you know, it's like crazy, because I eat, ask my friend, I always got a bag, I got nuts in here. I always have something to eat because I'm trying to at least get back up to the 120. Because once you start snatching stuff out, the weight drops. So I know this is the opposite issue that a lot of other people have, but it's an issue for me. So I go to a nutritionist. I have to go, I have an appointment Monday that I see, and an endocrinologist I go like 3 to 4 times, you know, at least 3 times a year, no, like 4 times a year. And they do and I was able to get, because I was able to get the A1C down on my own, but they still want me to get the weight back up to the 120. So, you know, it's like, it's work.
So your question is how to,
you want to know how to get your weight back up? Is that what you're saying?
Yes, because like now I make protein shakes. I put fruit in there, but I also put spinach.
Yeah, so I think just some very simple things without knowing like a lot of specifics about your issue is that a lot of times you may be doing things that are not whole fat. So a lot of people shy away from, let's say, whole fat dairy or whole fat whatever. You can have that for you. This is not applicable to everyone else. Maybe you have a whole fat yogurt, or if you're making a smoothie, you add things that have a more fat density in it because you're having some issues with keeping your weight in a range that's of the normal status.
I use the kefir for the smoothie.
Kefir, yeah, the kefir is going to be a lighter. It's not going to be as heavy as, like, let's say, a whole milk or something of that sort. I'm just using just a few examples, but the key thing is that you don't want to stick to things for you, and this is not applicable, I think, for most of us, that are going to have a much lower caloric density. So that's kind of the way I would think about it. Yeah.
I mean, you have to replace. If you're taking something away, you have to replace it with something. Okay? And again, everyone is different, and this is why it's so important to have a customized plan. So if you had excess weight, your BMI was 40, okay, and I said pull the carbohydrates out, and you started losing weight, and then your A1C went down, that's exactly what we're looking for. But if your BMI was already normal, like Dr. Winters was saying, it's likely a genetic component to why you're already developing prediabetes. So yes, I want you to decrease your processed carbohydrates so the sugar levels come down, but we have to replace that because I want your calorie intake to be about the same. I'm not trying to drop your calories, I'm not trying to drop your weight. So replacing that with the other 2 of the macros, right? So proteins, fats, healthy fats, adding that into the diet. When we talk about the protein shakes, when we talk about things like that, you have to replace what you're pulling out. So if you were just pulling out, your calories probably drop significantly and your weight's going to drop significantly. So from the conversation that we initially had when I told you I want you to reduce the carbohydrates, and I also need to follow that up with I'm going to replace it with, okay? If we don't have that conversation, then we're going to see that kind of outcome. So that's what we're talking about. But that's when you're normal weight, okay? So, but when we're dealing with excess weight, then that's a different conversation because I do want to bring the total energy input down as well. So it's a different approach, but your question is very important. It's not one size fits all approach for everybody. And I'm glad that the A1C has come down, but you have to make sure that the other macronutrients are replacing the carbohydrates that you're taking out.
Yes.